All right. So,
It's okay. You
my
working.
apologies. Oh my God. So this is my first week back. These are my first surgeries. So I operated Tuesday. That was my first case since June. This is my first time back on the robot since like May. So this is like
I know you
I'm
doing
back.
cartwheels. That's awesome. Well, that's the best Christmas present ever.
It's dope. I'm happy like a kid in the cancer. But I ain't gonna lie to because they don't have a robot that's signed on, so like it's like straight sticks.
See, you know,
My
I
God,
don't know what that means.
All right, so your surgery, right? All right, so this is the difference between a robot and so laparoscopic surgery is when you make small incisions and then you put tools into the belly and do like the work on the inside, right? So the robot is when you put the tools in the belly and then you attach this robot to it and then you sit at like pretty much like a simulated car-like thing and you just do the tools like this, sitting down, doing like this, seeing the full screen or whatever. Straight laparoscopic is standing on the side of the patient and doing this or what have you. So it's cool when it's like easy, but when it's like, there's absolutely no way I could have did your case that way. Impossible. I mean, no way. So robot is like the only way possible. So it's like the robot like can stand at an angle that we can't stand on because like the patient is like you're here and then we got to kind of tilt you on your head so the robot can kind of like sit damn near on your chest and look down. We can only stand on the side. Like I can't stand on your chest, so the robot allows you to get to an angle that a person can't get to. So it's like trying to do this, people fat and big, and it's horrible. But I got to get back in the swing of it. I got to teach residents. I mean, that's just what they have. So, you know, like I said, that hospital allows me to like operate on uninsured people with like horrible insurance that I couldn't even do before. So I got to stick it out until they get a robot. So I'm working on it, small steps, but I'm back moving. I'm back operating again. Good. So life is good.
Okay. I'm happy for you.
Cool.
Long time coming.
Thank you. Long time coming. Been
and I know you missed it.
Been a mess, but I missed it. You know, more importantly, all the people I promised surgeries to. You know, getting back to that for them. So it's needed to happen. All right, let's go ahead and hop into it. We are ready. Sorry, everybody. I apologize.
Yes, he definitely
late,
looks happy.
But
you can see the joy.
Yeah, I am. Yeah.
So somebody said in the comments you look happy.
Can help people. Yeah. It's depressing not being able to do what you do. Yeah. You know,
especially if that's what you know was your calling.
That's it. You know, so like I'm here. I can do it now. So it's much better.
All right.
Cool. Let's get into it. What we got?
Welcome everybody. Sorry for the delay. If you
my fault. It's all my fault.
It's for a good cause. You just helped somebody.
Yeah. She been waiting too. She been waiting all year for this surgery. She been on my ass. Like, so to do it and get it done for her is a good thing.
I know how it is to be waiting. Well, I wasn't waiting, but mine went faster than I wanted it to.
Yours was
and
on your own
when
way.
it was time, it went faster than I wanted it to. You remember you told me I had 6 to 8 weeks to get ready, and then you called me and was like, "Yo, came back. You going next available."
Let's go.
I was like, "Wait, what happened? Slow down."
Go.
All right. Well, welcome everybody. If you just joined in for the first time, I am Cola Red. I am one of Dr. Pierre's patients. We had my actual procedure, I had a robotic hysterectomy about a year ago. People had numerous questions. We shared the whole visit. We shared the whole journey. We talked about how I found them. We did office visits together and everything. And because of that interest, we started doing these monthly Q&A sessions for people to be able to ask their own health questions, whether you're going through a journey similar to mine or your own. This is Free Game Thursdays, where we get a chance to get real advice from someone who actually cares and will steer you in the right direction. All right, so if you want to ask a question tonight, I got some that were submitted already. You can request to join the live. If you request to join, it's almost like you get a free consultation on the spot. If you have a question that you want to drop in the chat, please use the comment bubble with the question mark. On the screen, it scrolls away. And when I scroll down, I'm not techie savvy. I might X out by accident. So please put it in the chat box. That's a lot easier for me to finagle with.
You getting better though.
You definitely have taught me a lot.
Came a long way.
Give you my social media. I was your social media resident.
Long way, man. She couldn't even get on IG.
Yeah,
now she a guru.
You definitely taught me the game on the social media too. And teenagers help sometimes too, because I go to them when I have they help a lot. All right, so I'm gonna kick it off with some submitted stuff. And then we'll go back and forth through the chat. And like I said, if you want to join, definitely feel free to request and we will pop you in here. All right, question number 1. Can you give your thoughts and recommendations on IVF for a 40-plus woman?
So I look at it like this. So with IVF, all right, and I'll talk to you guys just like I talk to every one of my patients. From the moment that you are born, right? Any woman, from the moment that you are born, your ovaries start to do like this. I don't care who you are, what you do, the life of your ovaries are doing like this. From the time you start menstruating on, it's doing this way. So once you are, hit upper 30s, early 40s, it start doing like this, right? It goes steep dive. Some women are, how that steep dive happens a little bit later. Some women happen a little bit earlier, even in your earlier 30s, right? So where you're at, you have to kind of figure out where that is. What I recommend, highly recommend, no matter where you're at, if you are 30 plus and you have absolutely no idea when you're going to get pregnant, you just know you want to get pregnant one day in the future, I would strongly recommend freezing your eggs, right? I strongly recommend that to anybody, because at least that gives you a time stamp of where you're at while you're figuring it out. You may not have a man, you may not have a plan, you may not have anything, but it at least time stamps that point in time for you, so that when you do figure it out, you have 30-something-year-old eggs as opposed to 40-something-year-old eggs. It makes a huge difference. And if you're 40-something, even if you're trying to figure it out, even if you're trying or what have you, it makes a lot of sense to time stamp and to freeze your eggs. As far as IVF is concerned, you really need to figure out if you're having infertility. So just like I said, people that are 30, 31, 32, 33, they have a higher chance of getting pregnant regularly. I still have patients that are 40, 41, 42, 43 that have absolutely no problem getting pregnant. Again, where anyone falls in that range, whether it's earlier or later, where you're having ovarian failure, you really don't know, right? Getting testing done to see where you're at is very, very valuable. And my advice to you is that if you are having infertility issues, so infertility is literally attempting to get pregnant for a year and being unsuccessful. That means unprotected sex. That means, timing, times of sex around ovulation, all of the things to make a concerted effort to try to get sex that doesn't happen for a year. That's infertility. If you're not there and it doesn't happen, you may not necessarily need to seek fertility treatments options. But if you are 40 plus, I would not wait that whole year. You know, I would, you know, give it a couple months. If it's not happening, see where you're at, see where your egg quality is at, see if your tubes are patent, see if the sperm count is right, because half of infertility, hear me clearly, is male factor. Every time we think about women not getting pregnant, we always think that it's because of the female. That's not true. Half of the time it is the man. So getting a semen analysis to see if it's your partner is also a big deal. So planning out what you're trying to do as far as getting pregnant is huge. So I recommend IVF if you have to go that route, but at least getting a fertility consult, which you could do with your OBGYN. There are simple labs that can be run to find out where your egg quality is at. Semen analysis can be done with your primary care physician for men. Thing called an HSG or SIS or hysterosalpingogram or saline sinohistogram. Those tests to see if your tubes are patent and if your cavity of your uterus is normal. All of these things are preliminary workups to find out if you are okay to get pregnant or if there is a problem, a potential problem. And seeing those things first before going to do the IVF and fertility workup are very, very valuable. Recommend to anybody.
All right. Question in the chat. I got my fibroids removed this past August. I tried to wait for you. I'll be 43 in March. How long do I have to wait to get pregnant after an open myomectomy?
6 months. 6 months after an open myomectomy to get pregnant. I am sorry for everybody that I promised surgery and you could not wait on me. I apologize. Like I said, I can only I did my best to get back to surgery as quick as I can. I'm back now. So everybody that I promised surgery that's been waiting, I'm really getting people on like quickly, right? So all of January is filled, February is filled. Like, so it's like, you know, if I promise you surgery, please call my office, reach out to me. I will follow through for you. I'm double booking patients, taking extra surgery days or whatever to make up for those things. So, but in answer to the question indirectly, after an open myomectomy, 6 months until you can actively start to get pregnant or try to get pregnant again. Okay. I think somebody trying to get on with us. Is he? Yep. I accepted her. I don't know why. I accepted her. I don't know why it didn't pop on. But okay. Go to the next question.
What are your thoughts on the Sonata treatment?
Okay, great question. So this is my honest assessment. Let me start off by saying this. I have to give out any disclosures to anybody. So I am paid by Hologic Surgical, meaning so the places that you see me going to teach is Excessa. So Excessa is a competitor of Sonata. So I say this, I have to say that because, you know, my answer can be skewed like, oh, well, you're just hating on, you know, Sonata. I'm not. Like, I'm all about fibroids, anything to treat fibroids, I'm all about it. So Sonata is a Sonata is a hysteroscopic radiofrequency ablation of fibroids. Excessa is a laparoscopic radiofrequency ablation of fibroids. So fancy words, fancy terminology. Hysteroscopic, going through the vagina, getting the fibroids through the vagina. Laparoscopic, going through the belly and addressing the fibroids through the belly. I go through the belly and address the fibroids through the belly. As far as Sonata is concerned, the biggest problem with Sonata right now is one, it's newer than Excessa is, and then two, and with that being said, it's the insurance verification or the insurance authorization of it is not there yet. So they don't have an actual code that you can bill for Sonata, which makes it problematic because a lot of hospitals are not accepting it. So getting skilled physicians that are doing it all, in abundance is problematic because it's just not paid for by insurances everywhere, right? So it's not widely accepted. That's problem number one. The other problem with it is that for me, it definitely addresses the fibroids that are submucosal, which is perfect. Those problems are those fibroids are very problematic. But the bigger problem for Sonata to me is when the fibroids are closer to the surface of the uterus, because you can't really see it. So you're going through the vagina, and you're using this tool to map out the fibroids and ablate or burn the fibroids, which is cool when you're like in the cavity of the uterus. But when you get closer to where the bowel and the internal organs are, it gets a little bit more dicey. It's really kind of like, like you have to really kind of really play it really carefully. Whereas Accessa, the difference is like laparoscopically, you can see straight in, and only you can visually see, but you also have an intraoperative ultrasound, which Sonata also has an ultrasound as well. They both have ultrasounds, but Accessa, you're able to actually see it, whereas Sonata, you're just strictly using the ultrasound. Accessa, you use visual as well as the ultrasound to be able to directly address the fibroids. So the question really wasn't really addressing the two, but I have to put that there because they're two different ways of doing it. I'm not against Sonata. I think Sonata has its uses in certain patients. I don't think that every patient is a candidate for Sonata. It's really if you have significant submucosal fibroid disease, meaning if the fibroids are pushing into the cavity or close to the cavity. If the fibroids are everywhere and like on the outer surfaces of the uterus, that's a more problematic, and a procedure like Accessa makes much more sense.
No,
That's
a
long ass answer, but
sometimes we don't get people that explain, so that was good.
Yeah, and anytime if I'm saying it to where, and I try to break it down like is backyard cousin talk as much as I can, but if I'm talking and it's like, all right, y'all, you sound too much like a doctor, be like, please somebody just chime in and be like, break that down better, like make it make sense for us, and I'll go and break it down some more, because sometimes I get a little verbose and complicated. I don't want to be complicated. That's the opposite of what I'm trying to do.
All right. Another question in the chat. Does ovarian cyst prevent pregnancy?
No. Actually, ovarian cyst. All right, so let's put it this way. So ovarian cysts are not created equal. There are multitudes of types of ovarian cysts. Ovarian cysts in of themselves, every woman of reproductive age will have ovarian cyst of some sort. Why is that? Every month when you ovulate, one of those eggs grows. It forms a cyst. That cyst ends up rupturing and releases an egg. So no matter who you are, if you are ovulating at a reproductive age, if I take an ultrasound, whether either an abdominal or transvaginal, if I take an ultrasound to any reproductive age woman at the right time of the month, you'll see a cyst on the ovary, right? That's why it's very frustrating when women go into the emergency room and they get an ultrasound, they're having pain, and the doctor tells them you have an ovarian cyst, and they run with this ovarian cyst theory like that's the whole problem causing them to have pain, when 9 times out of 10, usually those cysts are physiologic cysts of that shows that she's ovulating, or shows that they're normal, right? If you take that same ultrasound and ultrasound her at a different point of the cyst, different point of the month after the cyst ruptures, you won't see a cyst, right? So physiologic cysts are normal, so they're not nothing to be concerned about. They don't need to be removed. They're there for pregnancy because they're ruptured. They're going to release an egg. They're normal. pathologic cysts are different. So there are many different pathologic cysts, like dermoid cysts. So dermoid cysts are embryologic development, so like early uh, reproductive genes and tissue that form that are abnormal. They can form into cysts, which can, like, dermoid cysts can have hair in it and teeth in it sometimes. Like, these are cysts on the ovaries. Those are like probably the second most common. Well, no, I wouldn't say the second most common. That's not true. But they're very common. They can happen, but they look way different than a physiologic cyst. I don't really worry about cysts, honestly. You should not even worry about cysts unless they're like 5 or 6 centimeters or greater, right? And 5 or 6 centimeters or greater, and they're not physiologic, right? You also have like chocolate cysts, meaning cysts that are associated with endometriosis, where you have endometriotic lesions that will be in a cyst and they just keep rupturing, and they basically form like these big blood clots of cysts on ovaries. Those are painful. Those are different. When you do an ultrasound, you can tell the difference between a physiologic versus a pathologic cyst. So when you talk about ovarian cysts, they're two different lanes. Physiologic cysts, which are most common, are absolutely nothing to worry about. They don't impede pregnancy. They're actually normal and are meaning that you're ovulating and that you can get pregnant. Pathologic cysts actually can impede pregnancy. So like chocolate cysts, dermoid cysts, those cysts actually can be impediment to pregnancy. So just understanding which one you have, which lane you're in, is the answer to that question. But again, a majority of them are physiologic, meaning they're normal, nothing to worry about. So if your doctor just like, if you went to the ER, just somebody says, oh, you have ovarian cysts, get further explanation. Don't just take the term ovarian cyst and be like, all right, I got a problem. Find somebody that understands and can read ultrasounds and knows like what's a problem and what's not a problem.
And someone said in the comments, teeth in them, how would that happen?
So it's like embryologic development, right? So so just like, you know, so gametes, or half of the genes of a person come from the woman, half of them come from the man, right? So just like early development of sperm, early development of eggs. So when you have abnormal development of those genes, they can form a cyst, right? And that cyst is really like a early embryologic development just kind of going awry. It's not a pregnancy, it's not anything like that. It's just the abnormal formation of embryologic tissue or genetic tissue that just kind of goes awry. That's how like teeth and hair, it doesn't get much worse than that. It would be like teeth and hair and this really thick, nasty, sebaceous type yellow mucousy fluid that goes into a cyst. They call it dermoid cyst. They rarely turn into a cancer. They just can cause pain. They can increase the incidence of infertility. But that's how it forms. It's just abnormal cells, just like a cancer, just like just like a fibroid. It's just cells that just abnormally grow. Right. That's all.
If you just,
I tried to put this lady in that wanted to join. It's not.
Okay.
It's not letting her join.
Well, if you are just joining and you want to send a request to join, you can definitely do so. It'll connect, I guess. And also, there you go.
Oh, there she go.
I had to turn my microphone on. I think that's why.
Oh, okay. That's why.
I'm
right.
Well. Thank you for responding. I appreciate it. Basically, I don't know, back in June, I had fibroids removed, that myomectomy. I'm not good with all the terms. Everything was pretty good. And then they put an IUD in after to kind of help with my bleeding. I'm a teacher, so, you know, using the restroom isn't always the easiest when you teach kindergarten. So I couldn't always go. I was like bleeding so heavy that, you know, I was bleeding through my clothes and everything. So after the fibroids got removed in June, everything was pretty good, although it was summer, so I wasn't working. In September, I had a little bit of heavy bleeding. She did put an IUD in after to kind of, you know, hopefully that the bleeding would stop. Then
Sure.
in November, it was just out of control. I bled for like 21 days straight, heavy, like off and on. So I had another ultrasound. Fibroids are back.
How far? How
So
far was it? How
June was
far
when I had
was
them
the difference?
removed, June 6th. And then I had the ultrasound again on December 14th. And
Hmm.
the fibroids, they were more fibroids. The
How
biggest
big
one
were
was
you?
it was like
Did it say
7.4, I think. I believe
7.4
so.
centimeters? What
Is that
is
not
the?
sound right? Or is that sound? Oh, is that?
No, that's pretty
Okay,
big.
so maybe
That's
hold on, let me look. It
no, you
is, so
might be
let's
right.
see,
But that,
7.8 by 6.5 by 4.8. So,
mhm.
uh,
Yeah, that's that I have not seen that unless they did you got an
so
open
it
myomectomy?
was, she called it, let me go, I'm going back into her note.
What did they do? When she
No,
did a myomectomy, did
laparoscopically.
she do a big incision?
Mhm.
That's my problem.
So
See that?
that was the first
How did
one.
I know
So
that?
this one, so the first one, when she did it laparoscopically, it was like the biggest was 6 point something.
Hmm.
So when I went to her a couple weeks ago. She gave me lots of options. She has, I've
So
only
that's right. So
had
you've
one.
only had one surgery.
And so
Okay.
now she gave me 4 more options. She gave me, like she said, I could try ablation, the uterine ablation. She talked about, I saw one of your videos where you talked about where they clip and do the blood, they block the blood or whatever. No, I wasn't feeling that.
So
I saw that. She did, I am seeing at Brigham and Women's, I'm the one in Boston. I'm going to their laparoscopic clinic. She mentioned hysterectomy, but I don't know. I'm
how
50.
old
I
are you?
have
You
3
don't mind me
kids.
asking.
I do not plan on having any more children. So definitely I know.
All
So that
right.
Hysterectomy.
So this a real life consult. I'm glad you tune in because I want people to hear this, right? So number one, um, this is a prime example of why I am not a proponent of
okay.
laparoscopic myomectomies anymore, right? I am a laparoscopic surgeon. I love laparoscopic surgery with my heart. Cola had a laparoscopic hysterectomy, but I have done laparoscopic myomectomies for the first half of my career. I do not recommend anybody get laparoscopic myomectomies, and well, not always, but for the majority, I do not recommend laparoscopic myomectomies if they're not accompanied with something else. But for straight laparoscopic myomectomies, I'm no longer a proponent of the procedure. And now I really just don't perform them anymore. And your case is a big reason why, right? I just saw the last robotic myomectomy that I did. I believe I did her surgery in 2017. I just saw her uh, now. She has fibroids that have returned. They're not excessively large,
Mm-hmm.
but we're doing a hysterectomy. And her case really just shows and proves my point, just like your case proves my point. When you do a laparoscopic myomectomy, the only thing I can do is see. I can't feel, right? So if I can't feel it and I can't see it, it's going to stay, right? And that's the biggest thing with laparoscopic myomectomies. And people say, well, you can see it with an ultrasound and MRI. Yeah, you can, but you usually can't see them all. And the radiologist is not going to mention all of the fibroids that are there. They're going to mention the ones that they see and the ones they feel like listing. So with that being said, if I go in there and I see, oh, boom, there's a big 6 centimeter fibroid, I'm going to get that one. And boom, there's another 6 centimeter fibroid. You can have literally a 6 centimeter fibroid that's embedded into the muscle of your uterus that you may not even be able to see. It is, you can't differentiate if it's uterus or if it's actually a fibroid or what. And if that's the case, if you leave it, it's going to be there. That's why I would rather make a smaller incision, fill your uterus, fill the fibroid, and remove all of the fibroids out to help ensure that fibroids do not come back. It does not 100% guarantee that they will not. As long as you have a uterus intact, there is a possibility the fibroids may come back or may be there and grow larger, right? That's just, it is what it is. With that being said, when it comes to treatment of your fibroids or what have you, the question always remains, what is your plan for your uterus? Right? If you have a plan for it, if you say, I'm 50, I want to go and see what my IVF options are. I want to see if I can freeze me one egg and see if I can make this thing happen. God bless
No,
your
I have
soul.
3
You go
beautiful
right
children.
for it,
I'm
mama.
good.
God bless you. You do it. Absolutely. And so with that being said, I understand there's stigmas around hysterectomies. I understand it, but there makes no sense to struggle with fibroids and fibroid surgeries and going through it if you do not plan on using your uterus. So with that said, I would strongly recommend to do a hysterectomy. And with that being said, you can go right back through those small incisions and remove your uterus, and you never have to worry about fibroids again. But if you are undergo a fibroid surgery, I would not recommend doing a laparoscopic fibroid surgery again. Now, Excessa is an option for
The
you.
only
So
thing
what are
is
your
just the heavy
symptoms?
bleeding. Like I don't have any pain or anything. It's just the heavy bleeding.
Right. So with that being said, fibroids are not causing you to have bleeding, right? If you're comfortable with living with those fibroids for the rest of your life, then an option for you would
That
be an
was one option
endometrial
she
ablation.
did offer, yes.
That's what I was. Right. So I would say that would be probably the least invasive, highest yield option for treating your bleeding, other than hysterectomy. Now, within an ablation, I pretty much if it's done properly, that I can assure you that you're going to have decreased amount of bleeding. I cannot assure you that you will not, that you will be amenorrheic, meaning no periods at all. That no one can assure you of. But it would definitely be an effective way to treat your bleeding if you don't want to have another big surgery. You get right back to work, back to teaching, doing, your normal routine and going about your business. So that's another option. I would not and I would even recommend Excessa, except because fibroids are not your problem. Two things could be true at the same time. You can have abnormal bleeding. So you can give me you can give me a woman in your same circumstance, same age, demographics, live in the same area, you name it, all of it. And she has absolutely no fibroids. She can have just the same amount of bleeding as you. And a lot of times what I would put all my money on this happening with you is something called perimenopausal bleeding or anovulatory bleeding, meaning your ovaries have done that. They're doing this, right? And you're not ovulating regularly every month. So your body's confused. So you're not having, these periods are not coupled with ovulation. They're like, is she ovulating? The ovaries are not producing enough hormone. I don't know. We don't know what we're doing. Let's just make her bleed. Just flood her out, and that's basically what's happening. Your body's confused and you're just bleeding and bleeding and bleeding because it's not associated with ovulation. And so the fibroids, I could treat your fibroids. I could take your fibroids out. I could do all of those things. And I'm not trying to speak disparagingly about your doctor, whatever, but we wouldn't even had a conversation about fibroid surgery. I would have either talked to you about ablation or hysterectomy, right, back then. But now that you've had that and you see it, it really just shows you. Treated your fibroids, you still bleeding. That means fibroids have absolutely nothing to do with your bleeding. Either A, we're going to just treat the bleeding and leave the fibroids and the uterus intact with an ablation, or we're just going to take it out.
So do you think like the Mirena, like, is that just a waste of my time? That's just not helping.
It's not a waste of time per se.
Okay.
But it doesn't work for everybody. Right? For some people, it's a very effective treatment for abnormal uterine bleeding, but others it's not. But other options that you have, let's just go through it. So medication wise, so you do have medications like Myfembree, Orion. Those are for women with fibroids to help with bleeding, to help decrease the bleeding. So that they should cause a decrease in your bleeding. How much, it's variable. Mirena is an option. There are other hormones that will basically suppress your ovaries to help you with your bleeding as well. How much, again, is it going to do it? It's variable. You got to take her around and see which one's going to do it, which one's not. Like, you know, whatever your tolerance for that is, I don't know. But, you know, I personally wouldn't recommend doing that. I would either go into one of the surgical options. And if you're okay with your fibroids are not causing you to have pain with sex, fibroids are not causing you to have pain in your regular life, it's just bleeding, straight bleeding, then an endometrial ablation makes a lot of sense for you. But if you're just like, I don't even want to play around with it, I don't want to have a chance to have another period, robotic hysterectomy.
So, all right. Yeah, she did. I did the ablation she did before she, you know, mentioned it. And then we just ended up doing the surgery to remove them. She also said short term right now. She gave me something like tranexamic acid when I was bleeding.
That's another option. So Lysteta is tranexamic acid. That should help.
And
it doesn't work with everybody.
And she had me doing continuous birth control. I just started like 2 weeks ago. I don't know if that's even worth my time. No. All right, just stop it.
The risk versus benefit of that is not okay. All right. And people will have varying things about that. I don't routinely put you know, perimenopausal patients on birth control, or patients even after 40, unless we're talking about getting pregnant, you know, within 6 months to a year. I'm not messing around with estrogen. There's a small, even though it's small, but there's still a risk of blood clotting strokes with estrogen containing hormones. Even women that are menopausal and want hormone replacement therapy, that's the last line of defense, that I'm gonna give you hormones back, because there are potential side effects that can be. So
I think I'm going to try the ablation. I mean, I'm not opposed to a hysterectomy. My mother had a hysterectomy, but my thing is that I'm going to be in Chicago in May for my son's graduation at Loyola. I don't want to miss teaching. There's substitutes are hard to find. I want to take care of myself though too. So I know I need to put myself first. So
a robotic hysterectomy I just did this robotic hysterectomy. I literally, before we got on, while I was late, I did a robotic hysterectomy on this woman. She will be out of the hospital tomorrow. She will be pretty much in her. Cola can speak to it, Cola. You can speak to it more, and like nobody uterus and fibroids.
You don't have to say nobody, okay? You don't have to say nobody.
Cola had about 3 of these in her belly right here. This was Cola's belly, just walking around. It was like, Cola, you got a whole human walking around in your belly. Like, what are we doing here? You know, so it's like, you know, hers is a little bit more extreme, but again, you can be back in 1 to 2 weeks. Like I had a nurse that was back in 3 days, like literally. That's probably the record. So between 1 to 2 weeks, you should be able to walk around, do the things that you normally do. Things you can't do, you can't have sex for 2 months, can't lift anything super heavy, no ab work, but you can get on the elliptical, you can start doing aerobic exercise, you can start doing stuff.
I so appreciate your time. Thank you so much for giving me a second shot when I didn't have it right the first time. Thank you.
You're welcome. No problem. Thank you for sharing. I'm sure you helped somebody. All right. We'll talk to you.
All right. I'm going to go to a question in the chat. If you're trying to drop a question in the chat bubble, please use the bubble at the bottom with the question mark in it. Oh, somebody else trying to join?
Somebody else trying to. You want to do that,
it,
or you want to get
it's
another
easier to
question?
do the join. I mean, I can
The joint.
screenshot questions,
All right.
so we gonna keep doing this. So
All right. There we go. That's what consoles look like too, people. When y'all call me, like, this is how I talk and work stuff
Hello.
now.
How y'all doing?
good. How
What's happening?
I'm doing
Good. How
good.
you
I
doing?
think I'm kind of a reoccurring patient at this point.
I
But I do
remember.
have a question. Yes. So it's been a few months. I've been tuning in. So I have been what is it? Had the thyroid thing back in 2020. Had the IUD put in because I've been having like very extreme bleeding with very infrequent cycles. So had the IUD put in May. Now we're in December. I've been still experiencing the infrequent cycles, but then over these last couple of months, I've been getting really like heavy bleeding again. And it's very like infrequent,
Okay.
multiple times a month. It'll be like 2 or 3 days. I'm bleeding like excessive. And I say excessive like through a tampon and a pad while I'm at work. So they did tell me I'm
How old are you? If you don't
39.
mind me asking. Okay.
So
Oh,
I had some years ago had some benign like cysts kind of like surgical on my cervix. So cervical cancer does kind of run in my family, like running my family. So now I'm like,
it's not genetic. Just for everybody else,
oh,
cervical
okay.
cancer is not genetic.
So
It's not.
okay.
It's one of the only ones that's not genetic. So ovarian, breast, uterine, cervical cancer is caused by HPV, which is the most common sexually transmitted disease in the world, and it's the cause of cervical cancer.
Okay.
And so it's not genetic. Just for everybody. I'll just talk for
So
everybody. So, but
had
go ahead. I'm
that.
sorry.
So now I'm trying to figure out what should I do because they did tell me earlier in the year that I had fibroids. I think she said it was like maybe 5 centimeters, but she said it wasn't anything to be alarmed about. And it was like one kind of big one, but then a couple of small ones. So I was like, okay, understood. Now I'm kind of like, I'm having additional things where I've been having weight gain, really bad, like bloating in my stomach. So some days it'll be like bloated really bad, then it'll go back down to a normal size. So now I'm just trying to figure out what exactly should I be talking to the doctor about, because I have a virtual follow-up at the beginning of next month, and I'm just kind of at the point where I'm having a lot of back cramps, stomach cramps, back cramps. The bleeding is what is very alarming to me. And then, of course, throughout those times, I get these clots that are probably like a quarter size clots that come out as well. So I'm like, I don't know if I should be trying to see a different treatment option or kind of stick with the IUD, or what should I do?
All right. So with that, so you said a couple of things I want to address. So number one, with fibroids, so fibroids are significant for two different reasons: either size and or location. So it sounds like your fibroids are not big, but just because they're not big does not mean that they're not problematic. So if you like, you can have that 5 centimeter fibroid and it'd be 10 times worse than somebody that has a 15 centimeter fibroid, just depending on the location of that fibroid. So what I would need to see is where your fibroids are actually located. Because if you have an IUD in place and you're still bleeding, there's a possibility that those fibroids may be pushing into the cavity of your uterus. So if you got fibroids that are pushing into the cavity of your uterus, you can put 3 IUDs in there. It ain't gonna matter. You're still gonna bleed. You're gonna have problems. So understanding where the location of those fibroids is very important. And understanding too that, you know, again, things happen in life as you get older. And so for some women, it happens later. Some women it happens earlier. Two things could be true at the same time. One thing can be you have abnormal bleeding. Another thing could be that you have fibroids. They don't actually have to be, intimately related. We could take those fibroids out, treat those fibroids, and you still have abnormal bleeding. Because there could be a woman, same body size, same demographics as you, that has absolutely no fibroids and bleeding on an IUD the exact same way, right? Which will tell you that fibroids are not always the reason why you're having bleeding. So what I need to see is where those fibroids are located at, right? That'll tell me a lot as far as what makes sense for you, treatment option wise, right? So if you send me that ultrasound so I can take a look at it, and you can DM it to me, or you can email it to me, and I'll give you my assessment of like what I think would make most sense for you.
And would me having to take like hormone, I guess you could say supplements or replacements, have anything to do or have any attribute to me bleeding irregularly?
That's a great question, which we haven't gotten all into your business, but since we need to, what are you taking other medication?
So I take
what other medication?
Synthroid. I take 112 mcgs a day. So I know over this last year, they have tested me every 90 days just to see if I'm kind of regular with that. The last time when they tested before they put the IUD in, they said everything was fine. So she should be running some more labs here probably in January just to make sure they don't need to change the dosage. So it doesn't. Sometimes I have onset that, hyper or hypothyroidism is giving me issues. However, whenever that does happen, I try and follow up with endocrinology or I get with my PCM. So I'm just wondering, does that have anything to do with?
It most certainly can. But what other
I mean, I take
medications?
allergy pill daily. I take a probiotic daily, and then sometimes as needed ibuprofen, and then I have Celebrex.
Okay, so the most important thing is, yes, can hypothyroidism cause abnormal uterine bleeding? The answer to that is 100% yes. Controlled hypothyroidism, meaning that you're on a medication that's regulating your thyroid, should not be causing you to have bleeding. So if it's regulated well, then no, that should not be the source. But for everybody that's listening, if you have thyroid disease, it most certainly can cause you to have abnormal bleeding. Why? Because your brain is like the quarterback, right? Your brain it pretty much sends out signals to all glands in your body that secrete hormones. It sends them out to basically start doing them. So that goes for your thyroid, your pituitary, your hypothyroid, your ovaries, your adrenal glands, like everything that produces hormone, it starts from the brain. Your brain sends signals to it. Those hormones are very, very closely related, right? Meaning that they are very small structural differences in between them. So when one of them is completely off, it can cause everything else to be off, because when you have no thyroid in your system, your brain is trying to tell your body to produce thyroid, produce thyroid, produce thyroid. And because those molecules are so intimately close together, the hormone for your thyroid and the hormones that control your ovaries, like FSH, LH, they're so close that because your brain is putting out all of this stuff for your thyroid, it can also cause excess stuff to be put out to your ovary, which will cause abnormal bleeding. This might not be your case, but I'm just talking for somebody who's there that may have thyroid. Like, well, how does that cause bleeding? That's how it does it. But as far as your thyroid and bleeding is concerned, it sounds like they have control over it, so it may not be the problem, which would be a good thing to look at. But with that being said, Mirena doesn't work for everybody, right? And sometimes Mirena can work too well, meaning that Mirena, the progestin IUD, is meant to release a hormone to keep the lining of the uterus very thin, right? In some people, that lining can get too thin and basically cause the opposite of what you're trying to do, right? When that lining is thick and unstable, it can cause you to have abnormal bleeding. When it's really, really thin and unstable, it can also cause you to have abnormal bleeding. So it could be a possibility that the Mirena is working too well, and you may need a little bit of add back estrogen to counteract the bleeding of the Mirena, meaning that it's working, it's just working a little too well. So it's a lot of different things that could be going on with you, but we could talk a little bit more about it to see. But you know, I wouldn't necessarily give up on the Mirena just yet. I would look at those other things and I'm telling you about first, and to see if it's something else that needs to be adjusted, or if some of that add back therapy for the Mirena needs to happen to help you with your bleeding. But there is an answer for you. You know, it's just finding out and really looking close with what's going on in your body to figure out
And I
what
was
makes
just
the most
add
sense.
one last thing, because they were saying if I take out the IUD because of the bleeding and all of this, the only other option that they're giving me is the hysterectomy. And I'm like, I'm
Don't let anybody ever tell you that, right? Hysterectomy is never your only option. You got plenty of options, right? So just like the last lady that hopped on here, like ablation is also an option for you. Endometrial ablation is an option. If you take out maybe it's not the IUD, maybe it's you have submucosal fibroids and you need to have those addressed. So finding out the true cause of your problem and treating the true cause of your problem is the answer. Not just saying, oh, well, Mirena didn't work, now you just have the hysterectomy. That's not true. You have options. And you just need somebody to look at what's happening with you closely and figure it out, and then give you some very sound advice about what you need to try.
But thank you. I appreciate it.
Okay?
Thank you.
Well, my pleasure.
Bye.
Talk to you later.
All right. That was definitely good.
That was good.
All right, so I'm looking at the time. We like 10 minutes away, 12 minutes away, actually. All right. Do you have a recommendation for delaying your cycle for a vacation? I'm over 40 and I do not want to take birth control pills or other contraceptive medicines.
So delaying the cycle all right. So she wants to delay her cycle, but she doesn't want to take any hormonal options. Am I getting that right?
It says I do not want to take birth control pills or other contraceptive medicines, meds.
And you want to control the period. Menstrual cup. That's it. I mean, if you're not, so it's very simple, right? Your periods are controlled by hormones. It is hormone production from your ovaries, right? So I know there are misconceptions about, hormone suppressants, birth control, all of those things, but they're doing a very specific thing. They're going to the root source of the problem, and they are addressing the bleeding. So if you trick your body into believing that the hormones are being supposedly being secreted are not being secreted, that's how you stop cycles, because the hormone, it's basically showing that your brain is believing that things are happening that are not happening. If you're totally against that communication is going to happen. That's going to happen in your body, right? So unless you do something to alter that communication, then you can have a period. There are things like taking ibuprofen, tranexamic acid that will help decrease the amount of bleeding, whatever. But to just straight stop the period, you need some type of hormonal suppression to be able to do that. Unless you're just going to circumvent all of that. And I would say use a menstrual cup, which, you know, you're still going to have it, but nobody will know that you're bleeding. Nobody will ever see it. It won't get in the way of whatever you're trying to do. That's all I got for you. But yeah, there are plenty of different hormonal ways that, you know, I could give you to stop your period. But if you don't want none of that, it's not nobody. I don't have a magic wand to be able to just stop your body from doing what it do.
All right. Next question. First off, let me say that you both are very great and very informative. My question is, DocP only specializing in patients that need surgery or suffer from fibroids? I'm actually looking for a new gynecologist, but uncertain if he is taking patients for annual screenings, gynecological care, etc., etc.
Absolutely. Like I'm a gynecologist, you know, I'm a OBGYN. So now I'm actually seeing pregnant people again. Not many, but I am seeing pregnant people. So like a gynecologist, like even though I specialize in fibroids and surgeries or what have you, that's my niche or what have you, but I still am a general gynecologist. So I do have patients that are just normal annual visits, birth control, all of that type of stuff. It just so happens that just like, you know, people come to me specifically for, you know, big problems. But yeah, I still take regular patients that don't have big fibroids or big other problems. So yeah, so yes, that's the question. I still do
And
annuals
he's
and all
still my
that.
doctor too. Just waiting for my health. I'm
Yes,
just waiting to
see,
do my
yeah,
post-op
you
when
know,
my health spending
yeah,
account start over. All
yeah.
right. Next question in the chat. I am 47 with a 10-centimeter fibroid. I want to avoid major surgery. Would excessive make sense for me as an option?
I would say no. Yes and no. So Excessa is designed for fibroids that are less than 10 centimeters. That's really pushing the limit of fibroids for Excessa. I've done bigger fibroids than 10 centimeters with Excessa, but it really kind of depends on what your symptoms are. Because if your symptoms are bulk symptoms, meaning like pain with sex, cramping, urinary frequency or urgency, uh, generalized pelvic pain, those are things that fibroids can cause that Excessa will help control. But if you're just having bleeding is not something that Excessa will 100% control, because again, fibroids are not the only source of bleeding. So it really would depend on your symptoms and what you're trying to accomplish. If it's strictly bulk symptoms, then yes, Excessa will help you significantly. But if you're, you know, let's say for instance, and I don't know this person's story or history, but if you are trying to get a six pack and this bulge is in your belly and you need it to be gone, Excessa is not it's not the procedure for you, because it's going to shrink it volume. It's going to make it softer, but it's still going to be there. You know, so as long as you still is okay, if you're okay with it being there and you're more worried about the symptoms, then yes. But if you're more worried about the look and like the bulk or the bulge or what have you, then no, it may not be. So it really kind of just depends on what your goals are, what you're looking for, and what your actual symptoms are from your fibroids.
All right. This one,
But 10 centimeters is the maximum indication of what
all right. This
Excess is
one
for, though.
is for me, but I think it's a pretty good one. I think a lot of people will want to know. All right, Cola, what does your belly feel like now that you had a hysterectomy? Do you feel anything different? Like, do you have a sense of emptiness in the abdomen area now? Excellent question. So no, it doesn't feel
Excellent.
like a sense of emptiness. Like I don't even miss or know that it's gone. The only thing with me, and this is my case specifically, You didn't have to have any medical education to touch my stomach and feel that I had a whole bunch of stuff going on. So even when I was in Dr. P office, the office manager touched my stomach and you could tell something was in there. You might not have known it was fibroids. You might not have known the location and all that, but you could feel them. You can't feel that anymore. Like, you could touch my stomach and it probably feels like a normal, everybody else's stomach in the world. Like mine, you did not have to be a doctor to touch it. So that's the only difference. But as far as like emptiness in my gut or anything like that, absolutely not. I don't even know that it's gone. Oh yeah.
Other than you don't
Now
have
that is
no
an
bleeding
amazing
and
thing.
no
I
other
am
crap.
so glad that I don't have a period, because the heavy bleeding that I endure for years after year after year, I am thankful to be relieved of even having to look at a maxi pad or a tampon or both. In my situation, I had to combine them. So it's amazing.
And then I get the question all the time, speak on, do you still have sexual desires? Like, do you still, like, how's sex now? Is or whatever,
Oh
without a
yeah, that was
cervix?
the
Like, speak on
next
that.
question. Is it true that you need a cervix to have
Mhm.
sex? I don't have my cervix, and I've been able to resume normal sexual activity. Like he said, I did have to wait like 2 months, but other than that, my orgasms have not changed. My wetness has not changed. Tightness has not changed. You know, for me, you know, I feel like they're actually the same. So I don't have any complications with not having, I mean, I don't have to plan around a period. That's an amazing thing. I don't have to plan around it at all. My life is just consistently, like, I live every day, like, and you're living with no period, and I'm not in menopause yet. So it's like the best of both worlds. Yes, I had to wait 2 months.
2 months. You gotta heal. It's a hole at the top of
Yeah,
your
you
vagina. It
have
needs
to
time
wait
to
2
heal.
months. You can manage. You'll make up for it, but you won't have a period stopping you for
Be fine.
weeks at a time anymore. All right,
Right.
so we at 9:08, so it'll be like it's only 2 minutes left before, and I think it cuts us off.
All right.
So let me,
Well, we can do it. We can
okay,
do another one next week
well, next week,
or whatever.
no, I'll just check
Whenever
my
you
book
can.
real quick.
Whenever.
I think Thursday. Yeah, no, I could do next week. Yeah, I could do next week. All right, so I'm gonna screenshot some of these because it's a couple. It's not too many that I didn't get to, and I got a list. So. All right.
Bleeding is for the birds. Everybody be worried about hysterectomies, but if it, I mean, I don't just recommend hysterectomies for any and everybody. Like, again, they have their place.
Yeah.
You know, and if it's for you, it makes sense. If it's not for you, then fine. But people are just like, I'm just not getting it no matter what. It's like, okay, like, you don't want to have children. You don't want to deal with all of the mess you have to deal with. Like, it makes sense. You got to at least put it on the table.
Yeah, I agree.
As an option.
I mean, I don't know if I was worried about hysterectomy so much. I was just scared of surgery, period. Like, I didn't care what kind of surgery it was.
54 is too late to get surgery? No, 54 is not too late to get surgery. You absolutely can get surgery. It just really depends on what you got going on. But yeah, no, it's not too late to get surgery at 54. Vaginal cuff is what's left after you remove the cervix and the uterus. It's basically the top of the vagina just sewed up. So like the cervix connects. So the cervix. So in the uterus, you have your cervix. When you do a hysterectomy, you cut there, and you basically like cookie cut around there, and then you remove everything out through your vagina. It's a hole at the top of your vagina. You sew that hole up, that's the vaginal cuff. So it's just basically the vagina, where your cervix used to be at, right? With the void of your cervix just sewn up. That's what the vaginal cuff is.
All right. So yeah, we'll set up one for next week because I don't have anything blocked off for Thursday. So that's perfect. And thank you. I appreciate you always.
Thank
and
you.
Thanks everybody for joining.
54 years old, too late to have a child. Yeah, mama. You might probably missed your boat. Not to say that it hasn't been done in life, but you got to have a viable eggs and see if they're viable eggs, and then most likely you probably going to have a surrogate. It's an uphill battle. Not to say that it can't be done, but you also going to have to find a reproductive endocrinologist that is actually going to do it. Most of them cut off at 50 because their success rate is how they make their money. So, they can't like play around with too many people past 50 because they're not going to be very successful and they're going to have very poor success rates, and it's going to be a problem.
All right.
All right.
You want to keep going? I don't know if it's going to cut you off.
Cool. No. Yeah, it's going to cut off. That's fine. We'll do this again. Thanks everybody for tuning in. Sorry I was late. Stay tuned. We'll both. If you guys don't follow Cola, please follow her. Again, I talk to you guys from a physician perspective. Yes, I am a man. I don't have a uterus. I just deal with all women's issues, but she is the perfect person to talk to as far as like what surgery is like and going through the process. So if you guys don't follow her, please do. Send questions.
Yes, I definitely
we'll talk about
get
it
the
at the
patient
next
perspective and the woman's perspective. And if you're nervous about doctors, I can tell you a lot about that. So I've definitely been there through it all. So glad to share my journey and impact others. That's why I had to be you.
Awesome. I applaud you and I thank you. I thank you for everybody that they ain't even thanking you because you help a lot of people. Because people be coming up to me, I follow Cola.
Oh no, I get people that come up to me and say, I know you don't know me, but yeah.
Right. I know
I
you.
just change my hair a lot, so it's me though. All right. Well, thanks again, DocP, and I'll talk to you later.
All right, everybody. Y'all
Bye-bye.
be safe. All right, talk to you later. All right.